Hey everyone, Ryan here, and welcome back to our Orthodontics series. And this will be our final video where we go through 15 practice questions that test what you learned from the Orthodontics series. So this is everything that we talked about, and if you haven't already, I definitely recommend you to go back and watch the full series before attempting these questions so you can really test what you learned. And I broke down the material covered on the board exam into 11 videos of high yield information, and this information will really help you on the board exam. So I compiled 15 questions. Let's go through those right now. So question number 1, which of the following statements is correct? Go ahead, read through the answers, pause the video, and then we'll go over this together. All right, so this is a growth and development type of question, and it's asking about the types of ossification that the different bones of the craniofacial complex are created from. So let's go through, starting with the cranial vault, because that's what I've talked about first in our video series. The cranial vault is formed by intramembranous ossification, and that's at the fontanelles and the sutures, as well as the internal and external surfaces. So this is certainly not endochondral. There's no cartilage in the cranial vault. The cranial base consists of the ethmoid, sphenoid, and occipital bones at the skull base, and those are initially in cartilage. Then they ossify into bones, leaving behind synchondroses between those bones. And then we get endochondral ossification at those synchondroses through childhood and adulthood. So there's also technically some intramembranous growth at the surfaces of these bones in a lateral direction, but primarily this is endochondral. It's certainly not intramembranous only though. So this one is a little bit tricky, but if that were to be correct, I would want to see both endochondral and intramembranous for the cranial base. All right, and then for the maxilla, intramembranous ossification occurs at the sutures posterior and superior to the maxilla, and also to remodel the surfaces. So intramembranous is true, but it's not endochondral because there's no cartilage in the maxilla. So that's also incorrect. So we're left with A, and the mandible grows by both intramembranous and endochondral ossification. That is in fact correct. So intramembranous ossification is used to create the corpus, or the body, and the ramus embryologically, and then endochondral ossification is used to create the condylar cartilage embryologically, and then both forms of ossification continue through childhood and adulthood. Endochondral at the condyle, intramembranous at the surfaces everywhere else. So the correct answer for question number 1 is A. All right, question number 2. A child in the primary dentition is most likely to have which of the following clinical presentations? Go ahead, pause the video, and then we'll go over this together. So most young children, especially before the age of 3, present with minimal overbite or slight open bite in the primary dentition. The key here is primary dentition. And that's because habits are very, very common at this age, like thumb sucking or using a pacifier, which can contribute to a reduced overbite. But that's only temporary. That's not something that's going to hold through the mixed dentition and permanent dentition unless that habit stays constant throughout those years. So primary dentition, it's okay to see a decreased or reduced overbite. That's somewhat normal, and so that is something that we would likely see in the clinical presentation of a child if we're seeing them that early on. So a child in the primary dentition, this is a pretty typical appearance where we have very minimal overbite between those primary incisors. It's either decreased, reduced, or maybe even slightly open. So the answer here is B. All right, question number 3. A patient with trisomy 21 will usually have all of the following except. Go ahead, pause the video, and then we'll talk about this. So trisomy 21 is a relatively common genetic disease. It's caused by non-disjunction, which leads to an extra chromosome number 21. So we have 3 21st chromosomes, and it's correlated with a certain phenotype. So Down syndrome consists of certain phenotypic features that we might expect. Maxillary hypoplasia is one of them. Upslanted eyes is another. Relative macroglossia is an interesting term. So it's not true macroglossia, which would mean the tongue is just really, really big, but the tongue is big relative to the small maxilla and small overall mouth that a typical Down syndrome patient may have. So that is also true. So we can rule out so far A and C. And we also talked about upslanted eyes, the palpebral fissures, the openings of the eyes. So D is also true. So if we're looking for the exception, high caries risk is not correlated with this syndrome. Increased periodontal disease risk, yes, but not high caries risk. So the answer for this question is B. Question number 4. When class 3 elastics are used, the maxillary first molars experience movement in what direction or directions? Go ahead, pause the video, and then we'll talk about this. All right, so this question comes down to understanding force vectors, and specifically understanding the force vectors that are applied with certain rubber band patterns. So let's review that very briefly. And I know I'm flashing the answer here, but I definitely want to show you some of these pictures. So class 3 elastics are used by stretching a rubber band from anterior tooth in the lower arch, usually the canine, to a posterior tooth in the upper arch, usually the first molar. And we know when a rubber band is stretched, it pulls on both ends. So we can draw our force vector towards the center of that rubber band because it's going to be pulling in both directions. If we break that vector for this first molar into x and y axes, we have a mesial pull in the x-axis and an extrusive pull in the y-axis. So that maxillary first molar is experiencing both a mesial and an extrusive force. So the answer here is B. Now, just to review for class 2 elastics, again used by stretching a rubber band, this time from an anterior tooth in the upper arch, usually the canine, and a posterior tooth in the lower arch, usually the first molar. So here, the molar would be experiencing a mesial force and an extrusive force. That much is the same. Both cases for the canine, they're going to be experiencing distal force and an extrusive force. What changes is which arch is being affected. So interarch elastics will always apply an extrusive force, but the mesial versus distal depends on the direction that you're running those elastics and to which teeth you're running those elastics. So for this example, in this question, the answer is B, as we saw in this image right here. All right, question number 5. What occlusion is present when the mesiobuccal cusp of the permanent maxillary first molar is mesial to the buccal groove of the permanent mandibular first molar in centric relation? Go ahead, pause the video, and then we'll talk about this one. So this question is testing your understanding of the angle classification system for permanent molars. Now, class 1 occlusion means that the mesiobuccal cusp of that maxillary first molar is occluding with the buccal groove of the mandibular first molar. Those two things should be locking together. That's the correct molar relationship for ideal function and stability. Now we're class 2 if that upper molar is too far forward relative to the lower. We're class 3 if the upper molar is too far back relative to the lower. So in this case, that maxillary first molar is mesial. Another way to say that is too far forward. So it's too far. If it's too far forward of where it's supposed to be, that means that's a class 2 molar relationship. We can see that here, this is a class 1 where they're locking in nicely, class 2 where this is too far forward, class 3 where it's too far back. And this is explaining a class 2 dental situation. So the answer is B. It's not true that any of these are possible. In this specific example, that is in fact explaining a class 2 relationship. Now, it doesn't matter how much it's mesial to it. They're not asking if it's a full cusp class 2 or a half cusp class 2. It's just asking if it's class 2. All right, question number 6. What is the typical order of removing teeth if serial extraction is chosen as the treatment to alleviate severe crowding? Go ahead and pause the video and then we'll go through this together. All right, so for serial extraction, remember one key memory tool, and that's CD4, and which is conveniently also the name of that glycoprotein found on the surface of T helper cells. So if you can remember CD4, you know all you need to for these kinds of questions. So we know C, the C's refers to the primary canines in our ortho lingo, so we can rule out that one, we can rule out this one, and we have primary canines here and here, that's good. D's refer to primary first molars, so we have that in B. Whoops, we're definitely not taking out the permanent canines, and then the 4s are the permanent first premolars. So permanent is certainly doesn't need to be said, it's kind of understood, but we have the permanent first premolars there. Perfect. B is exactly what we're looking for, and that's the correct answer. All right, question number 7. Which of the following synchondroses closes last? Go ahead, pause the video, and then we'll go over this together. All right, so this is one of those kind of recapitulation questions. Do we know it or don't we know it? And the synchondroses have some interesting names here, but they're mostly in reference to where they're located along the cranial base and in between which bones they are. So the intersphenoid synchondrosis closes first at around, let's say, age 3. The intraoccipital synchondrosis is kind of far in the back, in the midway point in the occipital bone. We didn't touch on that during this series, but you don't need to know this per se, but it's age 4 around is when that one closes. The sphenoethmoid synchondrosis closes at around age 7, and we mentioned this in the series that the sphenooccipital is the laggiest synchondrosis, and this one closes last, late, and it could even be up to age, let's say, 18. There's a pretty long time of that one before it's closing fully. So the answer in this one is C. And if you want an axial viewpoint, this is looking, if we removed the brain and looking straight down at the base of the skull, here's our sphenoethmoid. That's here. The intersphenoid is here. Sphenooccipital is the laggiest one. Intraoccipital are back here. All right, question number 8. A child has a distal step in the primary dentition. Which of the following molar relationships is most likely to develop in the permanent dentition? Go ahead, pause the video, and then we'll go over this together. All right, so distal step means that we can draw a stair step along the distal surfaces of the primary molars. So this is our distal, this is our mesial, and we'll have our, of course, we're talking about steps, so we're in the primary dentition phase. We have that upper first primary molar. So if we were to draw the lower molar down here, well, this would be an example of a mesial step relationship because we can draw a stair step on the mesial side. If we drew it right underneath, this would be an example of flush terminal plane because those distal surfaces or the terminal planes are flush to each other. If we draw the lower molar down here, we have a stair step on the distal side, and it can support a little letter D right there. And so this is our distal step relationship. So we can see that the upper molar is too far forward relative to the lower molar, and that sounds like a class 2 situation. And it certainly is. Now, if we didn't spend so much time talking about this in our series, you may have guessed that, well, this doesn't sound like a very reliable predictive measure. And that's true for many of the relationships in the primary dentition, not true for the distal step. The distal step is almost 100% guaranteed going to be some level of class 2. So remember, when you have a distal step, you almost have a 100% chance, very, very close to 100% chance that you're going to end up with some level of class 2 in the permanent dentition. So the answer here is B. All right, question number 9. Which of the following orthodontic wire materials would be the best choice for a patient with a nickel allergy? Go ahead, pause the video, and then we'll go over this together. All right, so let's talk through some of these materials. These are all probably the 4 most common materials used in orthodontics today. And so beta titanium, also called TMA, which stands for titanium molybdenum alloy, this does not contain nickel. That, I'm kind of giving away the answer here, but that one does not contain nickel. Stainless steel does. It contains about 8% nickel and about 18% chromium. So if it has any amounts of nickel, not great for someone with an allergy. Nickel titanium, of course, isn't a good choice. It has nickel in the name, so that one's out as well. And cobalt chromium also has a small amount of nickel. So the answer for this one is the only material here that doesn't have any nickel in it, and that's beta titanium. Okay, question number 10. Which of the following conditions presents with glossoptosis, mandibular retrognathia, and cleft palate? Go ahead, pause the video, and then we'll talk about this one. Okay, so let's go through these one at a time. Pierre-Robin sequence involves a sequence of events that leads to the next. I almost said syndrome, but it is a sequence because it consists of dominoes that kind of tumble and hit into the next event and the next condition. So they're all linked together in that way. Treacher-Collins syndrome is a syndrome that includes an underdeveloped mandible, which we have here, underdeveloped ears, sometimes cleft palate, which we have here, and down-slanted eyes. Not sure about glossoptosis, though, but we do have 2 out of the 3, so we'll keep that one in mind. Hemifacial microsomia is a condition where one side of the face is smaller than the other, affecting the ear and the mandible. That doesn't really have to do with what we're talking about here, so that one we can rule out. And then fetal alcohol syndrome is a syndrome with an underdeveloped midface, an increased chance of cleft lip, not palate, and central nervous system issues. So fetal alcohol syndrome doesn't match up with what our question's describing. So Treacher-Collins, we had 2 out of the 3, not bad. Pierre-Robin sequence is where we have a sequence of events, specifically a small mandible early in life, which leads to backward displacement of the tongue, which is glossoptosis, which interferes with embryological palate development, often leading to cleft palate. So one domino leads next in Pierre-Robin sequence. The misleading part of this question is that the signs are not in the correct order. It's this one first, then this one, then this one. But that can happen on the exam, so don't let that throw you off. Again, be confident in what you know. You know a whole deal of information. And so the answer for this one is going to be A. Question number 11. Order the following orthognathic surgery procedures from lowest to highest chance of post-surgical relapse. And we have maxilla forward, mandible back, and maxilla up. Go ahead, pause the video, and then we'll go through this one together. All right, so this is a tough one, and I'm certainly not going easy on you guys in this video. I know a lot of these questions are on the tougher side, but if you're doing well so far, stick with it and keep it up. So there are multiple steps to this question, and I want to break it down for us real quick. So lowest to highest chance post-surgical relapse. That might be a little bit confusing. So let's reword that to most stable and predictable to least stable and predictable. So we have to recall our hierarchy of stability. Now, impacting the maxilla, which means moving it up, is one of the most stable movements that we can make in orthognathic surgery. So that's going to be towards the early part of our list. Setting the mandible back is one of the least stable movements that we can make. So 2 should be over here. And maxilla forward, a Lefort 1 advancement, is fairly stable as well. So that might be somewhere in the middle. So if we could take a stab at this one, we'd want 3 first, then 1, then 2 last. And lucky for us, we have 3, 1, 2 in that exact order, and that is the correct answer. Here is our hierarchy of stability from most stable and predictable to least stable and predictable, and that matches up with what we saw in the question. All right, question number 12. Which of the following space analyses predicts mesiodistal width of permanent canines and premolars using a prediction table and a sum of the widths of the lower incisors? Go ahead and pause the video, and then we'll talk through this one together. All right, so let's go through these one at a time and talk about what we know. So Tanaka-Johnston involves the sum of the width of the mandibular incisors. You take half of that, you plug it into this fancy equation, and that gets you your prediction. Doesn't involve a table though, so that one is out because that's an important part of this question. The Moyer's space analysis, you add the width of the mandibular incisors, you take that sum, and then refer to a prediction table. Well, that sounds pretty darn good, so we'll keep that one in mind. Nance and Hickson-Oldfather, they might pop up on the exam. They're older methods, not really used today anymore, and they used to involve measuring the lower incisors on the cast. You also evaluate periapical radiographs for part of your estimation, and you might use a prediction table as well. So these are involving x-rays, which were not included in the question. And so we're really left with Moyer's being the best answer here, involving both a prediction table and a sum of the widths of the lower incisors. And these two are going to be the ones that are more than likely going to be the answers that you're picking from in this kind of question. So the answer here is B. Question number 13. Order the following events that occur when heavy orthodontic force is applied to teeth. I'll let you read through the rest of these, and then we'll, so you can pause the video, and then we'll talk about this. Okay, so let's talk through the events for heavy force. So light force and heavy force are slightly different, so we have to make sure that we're thinking in our minds that right column that I had in that presentation on biology of tooth movement, and thinking through those rows of events. So the first thing that happens is the PDL is compressed on the pressure side and is stretched on the tension side. So that is certainly going to come first. So we're definitely looking for 3 being the first one. I might just scan through the answers, and I'm just going to eliminate those 2. If I'm taking my test, I'll just right click on those and cross those out. And then the PDL is going to undergo sterile necrosis, and it's actually going to die thanks to that heavy force. And so another word for that is hyalinization. So 1 is going to be the next event. Now I'm going down here. Oh, I'm going to rule that one out because I don't see 1 next. So this is looking pretty promising. And then next we're going to have a big delay after this part, and because we have to recruit osteoclasts from the nearest source, which is going to be the underlying bone marrow. This is called undermining resorption, which occurs in about 3 to 5 days. So 2 will be next. Okay, that looks good. And then finally, the tooth will be able to move within that remodeled socket in about 1 to 2 weeks. So 3124, that's looking pretty good. We're going to select that as our answer, and that is the correct answer. All right, so the first day of the Part 2 exam will be 400 questions with these orthodontic questions, just like the ones we talked about, spread throughout that exam. Then on the second day, you'll come back to do 100 more questions that are case-based. So you'll get information on a patient with some photos, x-rays, clinical charts, and then you'll be asked to answer a bunch of questions about that single patient. So question number 14 and 15 will be examples of questions pertaining to this kind of case-based thinking. So we have a 10-year-old child that presents to your clinic in the ugly duckling stage. The only chief complaint is an unesthetic space between their two front teeth, and this diastema is measured at just under 2 millimeters. What do you recommend as your preferred treatment option? So go ahead, pause the video, think through the question, and then we'll talk about this one. Okay, so the ugly duckling stage is going to be at around age 10, 11, 12, and that's where the 4 permanent incisors are in the upper and the lower, but there's this unappealing space between those two front teeth. Now, aesthetics is subjective, but quite a few children and their parents can be self-conscious about that space developing. If the diastema is less than 2 millimeters between those upper central incisors, that's considered normal. That's a normal stage of dental development. If it's greater than 2 millimeters, then we would likely have to intervene at some point to close that space. But if it's less than 2 millimeters, mesial eruption of the maxillary canines should close this space. And so if we're talking through the answer choices, waiting for the upper canines to erupt sounds like the perfect thing to do, because that 2 millimeters may improve in just the next year or so. So if we just wait a little bit longer, we won't have to do any kind of treatment, and that sounds really good to me. Bonding a 2x4 appliance might be a good option if you're trying to close a space larger than 2 millimeters. Delivering headgear might be for a severe overjet situation. Bonding full upper and lower braces is a very, I don't want to say aggressive, but that's a pretty bold treatment plan for a 10-year-old child with a whole bunch of baby teeth still in their mouth. So when in doubt, pick the most conservative option. In this case, the answer is A. All right, and question number 15. The child has a sister who is 8 years old. She has a unilateral posterior crossbite with a functional shift to the right. What do you recommend as your preferred treatment? So go ahead and pause the video, and then we'll go through this last question. So one of the main indications for phase 1 early treatment is posterior crossbite with a functional shift. And that's because we don't want this to impact their future development, either in a class 3 direction or in a skeletal asymmetric direction. So this is an important thing that we want to correct pretty early. Wait for the full permanent dentition? No, we actually want to step in and intervene. If we could have a preferred and recommended treatment, we'd want to do some kind of phase 1. Reverse pull headgear, that's for a complete underbite with early signs of skeletal class 3. So we're trying to do some early growth modification. That's not the case here. Using a lip bumper, that would be for moderate lower crowding. Again, that's not what we have here. A Hyrax expander is exactly what we want. We want some kind of rapid palatal expansion to relieve that posterior crossbite. Even if it's unilateral, we might get some overexpansion on one side, but more than likely, they're shifting into that position, and if we can relieve the posterior crossbite, they will no longer shift to the right, and they will be able to bite together with CR and MI pretty coincident. That's centric relation and maximum intercuspation at coincident areas. And so if we can get that resolved with a palatal expander, that's the perfect kind of treatment for this child. So the answer here is D, an expander to resolve the posterior crossbite. All right, and that's it for this video, guys. Thank you so much for watching. Please like this video if you enjoyed it, and I sincerely hope you enjoyed the Orthodontics series. It was certainly one of my favorite ones I've done so far, since I just love orthodontics so much. Please subscribe to this channel for much more on dentistry, and if you're interested in supporting this channel and what I do, check out my Patreon page below. I have an amazing amount of patrons over there. We have a great community going, and you can unlock extras like access to these video slides so you can take notes on them and practice questions for the board exams. So go check that out. The link will be in the description. Thanks again for watching, everyone, and I'll see you in the next video series.